In advanced economies, traditional physical occupational hazards have largely receded. Industrial threats of chemical exposure and heavy machinery are now replaced by modern, unobservable psychosocial stressors. These new pathogenic environments cannot be identified by direct physical or chemical measurements. Sensors cannot track the weight of an impending deadline or the instability of a work contract. To map these abstract psychosocial conditions to disease outcomes, researchers employ middle-range theories. These define specific features of work that can be identified and measured. One of the leading frameworks in this field is the effort-reward imbalance model, developed by Johannes Siegrist at the University of Düsseldorf. The model identifies the core of occupational stress as a breakdown of social reciprocity. This universal norm dictates that the effort spent by an employee must be reciprocated by equitable rewards, money, esteem, and career security. When this reciprocity fails, the clinical stakes are significant. Prospective studies indicate that the resulting state of frustration increases an employee's risk of cardiovascular disease and depression by 50 to 150%. Understanding modern pathology requires evaluating the health of the unobservable social contracts governing the workplace alongside the physical environment. For decades, occupational health was viewed through the demand control model, which focuses almost exclusively on how tasks are executed. This legacy pathway is driven by the notion of threatened control. When a job profile provides low decision latitude, it triggers the hypothalamic pituitary adrenocortical, or HPA, stress axis. The ERI model introduces a parallel pathway focused on threatened reward. This shifts focus from the loss of control to the frustration caused by a lack of social reciprocity. These states of severe reward frustration specifically activate the mesolimbic dopamine system. Once stimulated, this brain system chronically activates the autonomic and neuroendocrine stress axes. Over time, these sustained biological responses trigger functional and structural changes that lead to cardiovascular disease. This explains why employees with high decision latitude and advanced skills still develop profound stress pathologies. Even when an employee has total control over their tasks, the biological cost of failed social reciprocity remains constant. A feeling of unfairness is a measurable neurobiological pathogen capable of restructuring the physical body. If the biological cost is so high, we have to ask why employees continue to accept conditions of high effort and low reward. This imbalance is systematically driven by three specific conditions that force or persuade workers to maintain an unfair contract. The first condition is dependency. This is a structural constraint where workers lack alternative choices in the labor market. This is most common among unskilled labor, aging employees, or those on short-term contracts. For these groups, the risk of rejecting an unfair transaction is higher than the cost of the stress itself. The second condition is strategic choice. Here, workers voluntarily accept high-cost, low-gain conditions in the hope of improving their chances for career promotion later. Strategic choice carries high risk because it relies on insecure return expectancies. Long-lasting efforts frequently fail to result in the anticipated professional rewards. The third condition is overcommitment. This is an intrinsic psychological coping pattern characterized by an excessive need for approval and achievement. Overcommitment induces a perceptual distortion. The employee chronically underestimates actual task demands while overestimating their own coping resources, creating a non-reciprocal cycle they cannot assess. Structural market traps, career gambling, and psychological blind spots create the architecture that keeps workers locked into toxic employment contracts. To test this theory in large-scale studies, researchers translate these sociological concepts into a quantifiable metric. The primary tool for this is a standardized 23-item questionnaire. It measures 6 items for effort, 6 for overcommitment, and 11 representing the 3 dimensions of reward: financial, esteem, and job security. This mathematical logic places the effort score in the numerator as cost and the reward score as the denominator, or gain. When the ratio exceeds 1.0, it flags a pathogenic imbalance where work costs officially exceed the gains. Researchers validated this metric through prospective epidemiological studies, tracking employees over time. They confirmed that an ERI score predicts disease onset independently of other standard risk factors. This formula converts an unobservable social grievance into a highly predictive clinical data point. We can apply this biological model to the macro environment to see how modern globalized markets interact with these vulnerabilities. Technological shifts like telework and virtual networks have individualized task performance. This limits opportunities for direct interpersonal exchange, reducing the non-monetary rewards of recognition and esteem. Widespread corporate mergers and downsizing introduce high job instability, reducing stable alternatives and creating the structural dependency required to sustain unfair work contracts. These forces push down reward scales like job security and wages, while simultaneously demanding relentlessly higher effort to remain competitive. This creates a segmented labor market, a secure, skilled workforce on one side, and a massive, insecure population on non-standard contracts on the other. Economic globalization is not a neutral force. By degrading the terms of reciprocity, it acts as a macropathogen that actively exploits the neurobiology of vulnerable workers. The health impacts of this imbalance are not distributed equally across the economy. To measure this, researchers use a concept called the synergy index to test the interaction between socioeconomic status and ERI exposure. The data shows that while work stress affects everyone, the risk of cardiovascular and depressive disorders shows an exponential spike specifically in the lowest socioeconomic groups. Lower socioeconomic groups suffer compounding vulnerabilities, as their lack of alternative labor options results in hyperdependency, making them the most likely to be trapped in high-cost, low-gain contracts. Macroeconomic shifts toward labor market flexibility directly drive population pathophysiology. Improving public health requires intervening at the structural level of the social employment contract.